From your point of view, do you think that's a physiologic or a psychological disease? Yeah.
Well, yeah, I don't know, I'm not sure how you really
All away from him.
those two running backs.
Not enough
I mean,
immune
you're definitely
receptors in the brain. In excess of being
Hello. Are you on yet?
Oh,
Sorry.
You know, in July. Yeah.
Second place schedule, and he had the UFC South. He couldn't believe it.
Probably. On paper, we looked at it, it was second team.
Can everybody hear me okay if I just talk about my phone?
Not well. I was answering for you, John. I was answering for you.
What'd you say? Trying to read the lips.
He had a slump in his career too.
Right.
He said, Roger slumped didn't do as bad as his one. Used to
Very nice
feel-
of him to say that.
It was, you know, he got the third and most buddies.
No, I don't think so. I mean, I think that the business that he didn't do a lot of it.
It started when Rogers came in here, and Senator was happy.
I'm gonna try to talk really loud. Is that better? Can you hear me now? Mic is not working. Your microphone. Sorry. That's okay. I'll try to project. I think maybe it's Apple.
Yeah.
Good afternoon, everybody. Dr. Lerner is a pediatric gastroenterologist affiliated with Children's Hospital of Wisconsin in Milwaukee, and she's an instructor at the Medical College of Wisconsin. She has earned her medical degree from University of Illinois College of Medicine, completed her residency at Rush University Medical Center, and completed her fellowship with Medical College of Wisconsin. Her current focus of advanced endoscopic procedures and treating patients with inflammatory bowel disease and esophageal disorders. Thank you for coming. Thank you very much. I'm really happy to be here today and talk about making dysphagia easier to swallow. And I hope nobody in this room has had a dysphagia having their lunch. Very unfortunately, I have no disclosures to present during this meeting. And I want to talk a little bit about the objectives of my talk. The beginning of the talk will focus a little bit about infantile gastroesophageal reflux. We're going to try to identify a few kids with warning signs for eosinophilic esophagitis, discuss the limitation of current testing which is available for diagnosis of eosinophilic esophagitis, discuss the treatment options for this new disorder, and talk about the very new entity which was recently discovered, titled PPI-responsive eosinophilia. So let's go ahead and go to a case study. I also want to encourage you to stop me if there's something confusing or if you have a question. I have enough slides where we can make this more of an interactive discussion if you like to do it that way. So we start off by talking about an 11-month-old boy who was having non-bilious, non-body vomiting 5 to 8 times per day, which started about 4 months ago. He's also began to turn away from food. He does have a personal history of eczema, prolonged cough after illness, and a family history of asthma. Would you consider this to be concerning for reflux? Now with reflux, we know that the majority of patients, over 50% of infants,
will experience some degree of daily regurgitation. The symptoms will peak in 3 to 4 months of age and almost universally resolve by 12 to 14 months, with only 5% of kids still experiencing some influx at that age. But this is a tough symptom, so it's not unusual or surprising that a quarter of all patients and parents seek advice of a medical professional during the first year of life, specifically for reflux symptoms. The good news is that complications of infantile reflux are exceedingly rare. In studies where an endoscopy was done to investigate further reflux in infants, less than 5% of children were found to have any erosions in the esophagus. And even if you take all children up to age of 17, only 12% of them had any histologic or endoscopic evidence of GERD when investigated, with esophageal peptic ulcer disease and other concerning findings such as strictures even more rare than that. Interestingly, however, can you guess which were the 9th and the 14th most prescribed drugs to children under the age of 2 in 2010? I think you know where I'm getting at. This happens all the time. In fact, in that same year, over 358,000 prescriptions for prilosoprazole were given to children under the age of 1. And here's the issue. We don't have a validated symptom score to find the children who are actually true GERD versus children who are simply refluxing. And it's really impossible to tell the symptoms alone, as there's tons of symptoms that could be attributed to GERD, which parents report. But interestingly than that, does acid suppression actually work in infants? And I wanted to draw your attention to this invited review, which was published in the Journal of Pediatric Gastroenterology and Nutrition in 2012. And what these people were tasked to do is review the 3 randomized controlled trials that were done on this topic, including 1 study that was randomized to 2 different doses of acid suppression in children under the age of 1. The studies took place in over 4 to 8 weeks and were high quality. What these studies demonstrated is that despite having adequate acid suppression in all the children involved on the doses that they were using, there were no statistically significant differences in irritability, regurgitation, fussiness, or gagging in any of the studies. One concerning thing is, even within the short period of the study, that was only 4 to 8 weeks duration, they did find an increased risk of viral pneumonias in the children in the treatment groups. So what are we going to do? There are a quarter of patients calling us about reflux are not going to go away. So I think the treatment options are still there. First of all, of course, we have to rule out warning signs. Warning signs include weight loss, feeding refusal, recurrent pneumonias, neurologic or genetic problems, and concern for mechanical obstruction or infection. Once we know that those things are not present, we offer a lot of reassurance. These are the families we talk to a lot. We also encourage them to give a little bit of time for observation, as we know that this universally gets better. We have to get a good feeding history and make sure that they're not overfeeding their children. This can be difficult for exclusively breastfed parents. And then we try thickened formula, or some refluxic formulas which are on the market. Now, if there's still extremely fussy, or the vomiting does not improve, I think it's very reasonable to try extensively hydrolyzed or amino acid-based formulas. As some recent studies showed that these children, up to 30% of them, actually have a milk protein intolerance. If you're still concerned, then I think it's reasonable to refer to a gastroenterologist. Interestingly, recently people looked at probiotics, including lactobacillus. And in this meta-analysis, they found that for symptoms of colic and crying, not necessarily for reflux, but irritability, lactobacillus was more significantly associated with decrease in crying time than aspirin. And you can see here that the meta-analysis, especially for breastfed infants, favors probiotics for this reason. Now, we don't have enough data to know about dosing and recommendations and all that, so we rely on the pharma companies to help us with that. This is a really good guideline published a little while ago now, but things really haven't changed much. So I encourage you to read this in the Journal of Pediatric Gastroenterology, Hepatology, and Nutrition for management of reflux in pediatrics. So let's shift a little bit and talk about another different case. Now we have a 12-year-old boy with over-the-counter antacid has given him some minimum relief, but not complete. And his grandfather has a history of swallowing problems. Now, if you look at up to date, you actually don't even find eosinophilic esophagitis on the list of differential. And I think that speaks to the fact that it's a fairly new diagnosis, and I think even our resources haven't yet caught up. But what I want to point out here is that you look at, of course, the life-threatening stuff first, right? So does this child have some kind of unknown esophageal foreign body which has been retained? We do definitely find that possibly in a little bit younger children. Was there a cause of congestion? Is there an infection that's life-threatening? Is there something neurologic? The common things are problems with the oral cavity. Do they have a abscess tooth? Do they have peritonsillar abscess? And of course, the rare disorder, which is echolalia and neuromuscular diseases, you have to think about for a good physical history. But what about his specific story makes you think about eosinophilic esophagitis? Just to back up just slightly, I talked about how the literature is a little bit delayed on making us aware of these diagnoses, and that's not surprising. Up until the 1990s, we didn't know anything about eosinophils in the esophagus. In fact, it wasn't until 1993 when some of these authors, Dysphagia et al., reviewed cadaveric studies and found that in normal people, there is 0 eosinophils in the esophagus. It is not something that we find there. And in fact, Atwood and colleagues described that adults with normal pH studies were having dysphagia and many eosinophils in the esophagus. And that was really the first time we thought about eosinophilia and dysphagia together. Now, that makes eosinophilic esophagitis about 21 years old as a disease. But since then, it has been reported throughout most of the world, in all ethnicities, but it remains to be still a dominant disorder in the Caucasian males, with the incidence rate of about 1 in 10,000, which is equivalent to inflammatory bowel disease. There's a strong association with genetics of eosinophilic esophagitis with a familial recurrence rate of about 6.8%. And of course, if you ask a family, if you have a family history of EOE, they'll say no, because most of those people were not diagnosed. But I usually will say, my grandfather comes in for dilatations every so often. Or, yes, this person in my family has struggled to swallow, or has been on acid reflux medications all of their life. What's more interesting is that the sibling recurrence rate is about 80-fold that of the regular population, which, if I give you a perspective for that, for asthma, it's only 2-fold. And as most of our allergic diseases, eosinophilic esophagitis incidence is on the rise. Okay? Some articles are reporting about a 50% increase over the last decade, which is more than can be explained by increased diagnostic field. Why are we seeing more of it? Well, there's lots of theories. Is it because we're treating H. pylori? Are we using more PPIs than we need to? Is it early life antibiotic exposures or changes in the microbiome? Or is it the additives in our foods or synthetic food packaging? The jury is still out. But to go back to our case, we have an 11-month-old boy. The fact that he's a boy makes him more likely to have eosinophilia. 11 months is a little bit old for gastroesophageal reflux. Right? We said by 12 months, 95% of them have resolved. So there's something unusual about the fact that this started around the time he started eating solid foods. He's straying away from food. Now that's signaling slightly of concern for a feeding disorder. He's got ectopic history personally, and that in the family, which also puts him in a higher risk category. But what's important to note about eosinophilic esophagitis is that symptoms actually vary by the age you are at which you get the disease. We know in infancy, eating disorders and vomiting are the predominant symptoms. By the time kids get to be school aged, abdominal pain and dysphagia surface, and then as adults, we start to see predominantly dysphagia and food impactions in our teens. The Vanderbilt University did a similar study in 2011 and added a few more signs and symptoms to the presentations, including GERD in school-age kids and weight loss and chest pains in the older cohort. love is that children are incredibly resilient, and they will get used to their symptoms. In fact, if you ever ask a child if they have trouble swallowing, they will almost always say no, because they don't know what it's like to swallow normally. So what do we ask? How long does it take them to eat? Most children will be able to finish a meal within 20 minutes. Okay, I mean, if you can get a kid to sit for more than that, it's almost impossible, right? They're in and out. But these kids usually wait 45 to 60 minutes to get a normal amount of food in. They will chew excessively. They will use water or some other drinks to help them swallow, and they will often swallow with each bite. They will start to avoid hard to swallow foods. And interestingly, soft breads tend to be difficult because they get meats get difficult, and they progressively get to be pickier and pickier eaters. At some point, you may end up starting to see weight loss. Okay? I can't stress how important it is to ask these questions. But really, what we get at the bottom is that we're trying to see if they're having dysphagia. Right? That's what we're sort of getting at. So how good is dysphagia as a symptom in predicting the risk of eosinophilia in the esophagus? So this study done in Australia, excluded motor, mechanical, and neurologic causes of dysphagia. And then they saw, based on all kinds of questions I just discussed, how good was the signs and symptoms of dysphagia to predict eosinophilia on endoscopy. And they found that in those kids who had dysphagia, 67% of them had significant eosinophilia at the time of investigation. And that's a pretty good positive predictive value for a question. But you can see that these kids also had significantly more history of ectopic conditions than their cohorts who had a normal endoscopy, but their GERD symptoms were the same as those who had a normal endoscopy. So that won't help us. What is the most important symptom association, though, is if you have a young male with a food impaction or a history of a food impaction. That basically equals EOE until proven otherwise. And that child absolutely needs an endoscopy for diagnosis. So once we get the question squared away, we think the child is at risk, they need to undergo an endoscopy. This is what a normal esophagus looks like. What you can see here is these vascular markers. There's some light reflection from the camera, and it generally looks pretty clear and even. Once we get into EOE, we start to see what we call linear furrowing. You can see these lines going down. We get mucosal edema, which removes the vascular markers from the esophagus. Later in the game, we get rings, concentric rings down the esophagus, which signals fibrosis. We call that trachealization. White exudates, which can sometimes be confused for candidal esophagitis, but these are really eosinophilic microabscesses. And ultimately, they end up with esophageal dysfunction and food impactions. On histology, as you see on the left, is a normal esophageal specimen. With eosinophilic esophagitis, you will start to get intraepithelial eosinophils with microabscess formation, generally at the tip of the epithelium. You will get papillary lengthening and basilar expansion. Sometimes you actually get deeper disease, but we can't sample that yet. Over 15 eosinophils per pi-hour field is required to make a diagnosis. But there's no one thing that will make a diagnosis of eosinophilic esophagitis. It is a clinical pathologic diagnosis. In the last 5 years, we've actually learned about the natural history of disease. And they're now concerned that if untreated, it will end up progressing to fibrosis. And what Schofer and colleagues showed, when they evaluated 200 patients in the Swiss EOE database, what they did is they correlated delay in diagnosis in over 20 years to the risk of stricture formation. And they found that if you were diagnosed within 2 years, you had a risk of stricture about 46%, but if you were diagnosed with over 20 years of symptoms, it was 87%. Basically, for every, the risk of fibrosis doubles for every 10 years that you're not diagnosed. Here you can see the longitudinal tears of a mucosal layer caused by just passing the endoscope. Right here. And you can see the CT with the expansion of the esophageal wall. And this is something that we can't even tell endoscopically because it's the deep muscular layers of the esophagus. So to briefly discuss the pathophysiology. What we think happens is you have to have a genetically susceptible individual, somebody with history of ectopic conditions, who has a barrier dysfunction in the esophagus. This barrier dysfunction actually allows for food allergens, which is the most commonly considered trigger for eosinophilic esophagitis, but also in a small degree aeroallergens to trigger a Th2-mediated immune response, which then leads to chronic inflammation, sensitization, and esophageal dysfunction. What's even more important is a lot of these children live with much more common comorbid conditions. If you see here, the risk of asthma, allergic rhinitis, and atopic dermatitis is at the top, and that's what's in the general population. And you can see how multiple studies describe up to 50 to 60% comorbidities of these same diseases in children with EOE. What I find even more interesting is that this is a study done just a year ago, looking at the risk of airway hypersensitivity in children with eosinophilic esophagitis. You can see that the known cohort of kids with EOE was about 20%. What these investigators did is they took kids age 7 to 18 in a cross-sectional prospective study and conducted methylene bronchia challenges in them, just in the healthy controls and in kids with known EOE. By the end of the study, what they found is that when you included kids with known EOE and those with undiagnosed asthma, you ended up with airway bronchial hyperresponsiveness in over 70% of the children, meaning that we're probably underdiagnosing asthma or airway hyperresponsiveness in these children. It is also significantly more common for these kids to have IgE-mediated food allergy, which we don't believe EOE is. Where the general population has about 1 to 5% of IgE-mediated food allergies, these kids can have up to 24%. So it's really important to ensure that they have seen an allergist, this is being managed, and then they also have an EpiPen and know how to use that if they have been diagnosed with these conditions. Let's talk a little bit about treatment and why it's so important. The exciting thing about this disease is that this is one in which treatment actually can reverse disease and reverse fibrosis. As we saw that if delayed in diagnosis leads to fibrosis, treatment may actually regain some esophageal function. And you can see here, this is a trichrome stain with blue showing fibrotic tissue, and you can see how there's significantly less fibrotic tissue after treatment. This is a busy slide, and I want to take you through it a little bit. The way we discuss treatment in eosinophilic esophagitis is by degree of side effects, degree of difficulty, psychological effects, medical side effects, and acceptance by patients. It's also significantly more likely that a patient is going to accept a more challenging treatment is if they feel unwell rather than if they feel well. And it's difficult because most kids with eosinophilic esophagitis don't feel sick day to day. So what we have is an elemental diet, empiric elimination diet, which I'll talk about in a little bit, guided elimination diet, which is kind of falling out of favor, and that was based on allergy testing, topical steroids, and systemic steroids and dilatation, dilatation being predominantly used in the adult population. Until recently, skin prick and ATP patch testing were a prerequisite for treatment discussions in in evaluation for allergic foods and EOE, and that has recently fallen out of favor, and I'll tell you why. All of these kids at university were being sent to allergists before they received gastroenterologists, and this has really changed. So as you can see here, this is again a large study, meta-analysis, looking at allergy test-directed diets and elemental diets, as well as 4-food and 6-food elimination. And you can see that allergy testing-directed diets in adults only led to about a 40% response rate, and in children a 47% response rate. The 6-food elimination diet, which eliminates 6 of the most common allergens that we know about, led to about a 72% response rate, and the 4-food to about 53 in adults and 16 children. So if you had a choice of which treatment modality to use, you may just eliminate empirically the foods that we know are allergic rather than go through allergy testing and pick those foods for elimination. You can also see that milk elimination leads to close to 68% success rate, as it tends to be the highest allergic food for children with EOE. So when we talk about empirical elimination, the sixth food is dairy, egg, meat, soy, nuts, and shellfish, which you can imagine to be a fairly complex diet for a child to undergo. And the fourth food is dairy, egg, meat, and legumes, or mostly soy. Although it's very effective and safe treatment, diet elimination is burdensome for the family. There's also concern for weight loss and micronutrient deficiency. A trained dietitian really needs to be a part of this treatment team because we've seen a number of kids, and remember, these kids can actually come out of infancy with feeding disorders. So if they come to us and we take them off the 3 or 4 foods that they're actually still eating, you risk significant feeding disorders on top of what they've already experienced. So this becomes a very challenging discussion with the family and discussion about risks or benefits of each treatment choice. Now, it has also been recently discussed that tolerance to foods that are eliminated that have been shown to be allergic is very unlikely, and only about 8% will ever be able to reintroduce the food that was removed later in life. The other very challenging thing about diet elimination is that we don't have any objective symptoms to correlate with esophageal eosinophilia. So how a patient feels has really nothing to do with how inflamed their esophagus is. And what that leads us to do is a series of endoscopies, which means that every food you add back in requires an endoscopic evaluation. And you can imagine that can be very challenging. In this adult study, it required up to 10 endoscopies a month in some patients to determine which foods they were allergic to. Now, it's incredibly important if a family chooses this treatment option that nobody changes their diet while they're on the treatment, going through their treatment, because a change in diet may actually make an endoscopic assessment useless, because we won't be able to answer whether or not that food is actually a trigger.
How long between each of those?
About 2 months. Let's talk about medication. The two mainstay medications for treatment of eosinophilic esophagitis. Now, this is actually fairly accepted by patients and accepted fairly well. They tend to be safe, have a low side effect index, and pretty effective. Fluticasone, as you know, is approved for asthma. Now, there is no FDA-approved medications for EOE. They're all off-label use, and sometimes that puts us into trouble with insurance companies because they want to suggest some other modality of therapy that doesn't really work for EOE. The typical doses you can see there are listed. Swallow budesonide is the nebulizer breast fuels that we ask the family to break open and mix with a sweetener, and they drink that twice a day. We ask them not to drink or eat anything for 30 minutes after swallow, and this is really used as a topical therapy, right? It's coating the esophagus and it's decreasing the inflammation that way. Very small amount of these are absorbed systemically, so the side effects are pretty minimal. But about 25% of children we treat don't respond to these medications and require either dose escalation or additional food elimination on top of this. So you will see some kids who are both on this and, for example, elimination of all dairy protein. Let's go back to our case study. What about this case makes us think that he might be at risk for eosinophilic esophagitis? Well, we already said that he's a boy. He has personal history of asthma and eczema, and he's got dysphagia, which we know is a pretty concerning sign for child disease. He's becoming a picky eater, and he's got a family history of swallowing problems. His endoscopy was consistent. It had mucosal edema. You can see some of the white exudates. You can see that we don't see any vascular markings. We don't have any rings in him yet. But interestingly, he was placed on 2 months of high-dose acid blocker treatment, and his endoscopy and histology are completely normal. So what do we do with this? Is this really the worst case of reflux we've ever seen? So the water gets a little muddier, and if we said that EOE is about 20 years old, then PPI reads like a toddler who's 2 years old, and it really become very, very difficult to characterize. But this actually led to a change in guidelines, because now that we know that proton pump responsive eosinophilia exists, before we can diagnose somebody with eosinophilic esophagitis, they must undergo 2 months trial of high-dose acid blocker therapy to know whether or not an acid blocker will actually resolve their eosinophilia and symptoms. The feeling is that this mechanism is actually acid-independent, anti-inflammatory effect of PPI therapy. PPIs have been shown in basic science to inhibit IL-13 and IL-4-induced eotaxin-3, which are known inflammatory markers of eosinophilic esophagitis. And then they have a direct effect on bacteria and the microbiome of the esophagus, and they actually improve mucosal integrity, all which may decrease antigen presentation to the immune cells in the esophagus. And you can see in the study that multiple studies have done this, and they show about a 30 to 60% response rate to PPI in children and adults with esophageal eosinophilia. So, added to our list of medications which we can use, we added proton pump inhibitor as well. Let's talk a little bit about side effects. The most dreaded side effect of swallowed steroids, and inhaled steroids actually for that matter, is esophageal candidiasis. In the literature, it's reported anywhere from 15 to 20% of patients on repeat endoscopy have this. As a patient once told me, who was a very articulate teenage girl, it's like I swallowed a wet sock. But not everybody will tell you that they're having symptoms. Their symptoms may just recur of the exact symptoms they started with, which is dysphagia. Unfortunately, the only way to evaluate for this is another endoscopy. But it should be looked at. The other thing we monitor for closely is growth. This is extremely rarely a complication of swallowed steroids, but we still monitor it very closely, just like we do for asthma. There's increasing evidence that there's some concern for adrenal insufficiency for kids on higher doses of swallowed steroids. This is more common in kids who are concurrently treated with swallowed steroids for other reasons, allergic rhinitis, asthma, and EOE. The total dose of inhaled and swallowed steroids ends up having a possibility of about 10% to decrease the adrenal function. And I have started having this discussion with the families because if they're in a car accident or in the ICU, they need to let their doctors be aware that it's possible. Now, if you've been paying attention to the media at all, or listening to the radio, people have heard some kind of horrific side effects of acid blocker therapy in the last 2 years, and they seem to just be accumulating over time. Some claim that it reduces the risk of dementia. Recently, there was some study that found that it reduced the risk of heart attacks. What do we tell our patients about this? In reality, the common side effects of PPI therapy are about headaches, diarrhea, constipation, and nausea. I see constipation more than I see diarrhea. But these are all the things that have been reported. In terms of actual correlation studies that we have, because the rest of them are really association studies, which are not very high quality data. They're basically insurance database searches. The ones that we know that are realistic are increased risk of C. diff infections and pneumonia and pneumonitis. And I do disclose that before I started PPI therapy. So let's recap a little bit. To put the whole picture together, we have a person who is at risk for eosinophilic esophagitis genetically with an appropriate history, who has a evolving symptom profile over their lifetime, starting with eating disorders, stretching to possibly abdominal pain, reflux symptoms, and then eventually dysphagia. We have the appropriate histologic exam findings, which can vary. And we have the demographics that go along with the disease complex. The important thing to know is that not one of these quartiles in the circle make the diagnosis of EOE. Because we saw that you can have reflux that can cause similar symptoms, you can have PPID, you can have other conditions that can present very similarly. So you need all of these conditions to really diagnose it. It's really a clinical epidemiologic diagnosis. It is also important for us to think about screening children who fit this paradigm for dysphagia with appropriate questions. So just briefly, just to review, there's no good evidence that PPI therapy in infants works to decrease regurgitation. A trial of hypoallergenic formula or dairy exclusion from breastfed mothers may be more effective. A trial of probiotic may be more effective. Evaluation for EOE in this age, if symptoms recur later in age or don't improve, is warranted. Symptom of EOE differ by age, but may look like GERD. We need to screen for dysphagia in kids with atopic conditions, including asthma. And diet, swallowed steroids, and PPIs can be effective for treatment of eosinophilic inflammation. And as we saw before, early diagnosis actually changes the course of disease, and we can prevent fibrosis and esophageal dysfunction if diagnosed and treated quickly. I'll take some questions.
So, there's two questions. One is there an animal model for EOE?
There's not. There's not.
My second question is whether, let's say, GI specialist, have you encountered, does the child have to be eating through the esophagus? So if it's a G-tube fed child, do they develop anything resembling?
Yes, yes they do. There's actually, when people look at the genetic biomarkers that have been found to be positive for eosinophilic esophagitis, it is the trafficking of information to the esophagus that's the problem. It's not where they are actually ingesting the food protein. So the food protein can be G2, can be J2, but the esophageal inflammation will occur only in the esophagus.
Any research looking at whether breastfeeding or the duration of breastfeeding may be protective?
It's a great question. I know there's a lot of people looking at that right now. There haven't been any conclusive studies yet, and I think only because the disease is so young. So to be able to really look at breastfeeding and look at 4, 5, 6 years out, we just really haven't had the time frame to be able to look at that. I think people suspect that may be true, as it is true for some asthmatic, allergic rhinitis, food allergies, but there's no clear evidence that that's true as of yet.
Once you start these kids on treatment, how long do you treat them?
Once you start them on treatment, you treat them for life. Because looking at some of the Swiss database now, they have the best studies because they have basically universal health care and all of their patients are in the same database. So they can really look at these large data sets. And what they find is that looking 15 years or so into it, when children or these adults that are reintroduced to the food, let's say that they've eliminated, only about 8% of them are actually able to safely tolerate the food after. Now remember, they're asymptomatic, right? So if we took somebody off 4 foods or 6 foods for a short period of time, our goal is really to put as many foods back in the diet as possible and only identify the 1 or 2 causative agents. And those are the foods that they have to stay off. Now, the treatment may actually change over time because a family may be really against steroids for their patient, for their child, but a teenager may say, I want to have pizza. And so we have these conversations all the time because for the teenager, it's much easier to take a puffer a few times a day than to avoid food when they're going away to college. And so the modality may change. And since the PPI read came out, a lot of these children are now being exposed to acid blocker therapy because when they were diagnosed, that wasn't a guideline. So now we're trialing a lot of these kids on the acid blockers to see if maybe you can introduce some foods if they were to take an acid blocker twice a day or once a day. Now there's some centers in the country, there's a lot of adult gastroenterologists who don't treat these patients until they become symptomatic. And what they're finding is, if you were found to have eosinophilic esophagitis at the age of 40, and you can go in once every 6 months and get your esophagus dilated, that may be something you prefer rather than taking medications lifelong. And so that's an option that is given to the adult. I think most of the pediatricians don't feel that way.
For the infants with GER, hyperalbumic formula, are the hydrolysate formulas sufficient, or do you have to go to the elemental formula?
Majority of the time, the hydrolysate formulas are sufficient. Now with the hydrolysate formulas and elemental formulas, the difficulty we find most of the times is if the kid is older, they won't accept them, right? So if it's an exclusively breastfed child, if you're really concerned, you can have the mother take out dairy and soy or just dairy for a while until symptoms get better. gradually mix the breast milk with the formula over time to see if they can get used to the taste. So they'll do a quarter formula, 2/3 breast milk, and over the next few weeks they can try to do that. The other thing is if the formula made no change, I will make sure to see them back every 2 to 3 weeks to take them off that formula, because it's about 2 to 3 times the cost of regular formula, and as you know, it's a huge financial burden to the family to stay on a formula that made no difference. So again, all of these are really therapeutic trials. Now some people actually, they say, I can't believe you're telling me you're not going to give me a PPI. My other child was on PPI and it made a gigantic difference for me. So I think in some cases that may be true. We just don't know. The studies don't support, the evidence doesn't support it. But I think if a child is started on PPI therapy, it needs to be weaned. What we see often is that children actually end up on PPI therapy lifelong when they're started in infancy. And when they come to our clinic, it's actually a huge battle to try to take them off of it because they feel like it was a miraculous drug, which may have been the natural course of the disease, right? We know it just gets better. So it's very, very challenging. So I often have to have a conversation about viral pneumonias, especially in kids who are, let's say, otherwise predisposed to pulmonary complications. I really try very hard not to start them.
When you're talking about the PPI evidence, is that the same for like your ranitidine too, or is same idea, doesn't help, or?
As far as we know, it doesn't help. In infantile reflux, the acidification of the esophagus has very little to do with the symptom, right? Majority of their reflux are actually non-acid. So we also are getting into the concept of bile acid reflux, for which acid blockers are not effective, and we think that's actually more caustic. Let's say we're talking more about the teenage group now and the adult group. It's actually more caustic to the esophagus than stomach acid. So I think we have to be honest about what we're trying to treat, right? And what we're treating is a symptom. So things like lateral lying position for post-feeding, smaller, more frequent meals, elevating out of bed. I mean, those things are effective. And I think a lot of it is really reassurance. Unless the kid is really failing to thrive, because that's a very different thing. And I really truly think that requires a more thorough investigation before we decide to do 6 months of acid block. The other thing about acid blockers is if you're using them in adults, in older kids, there was a recent study a few years back that looked at symptoms post-exposure to acid blockade, and they took asymptomatic people, they gave them acid blockers for about a month, and then they culturally stopped the acid blocker. And the majority of those patients had symptoms post-stopping the acid blocker. And so it kind of made people feel like they couldn't stop it, because all of a sudden they stopped their acid blocker and they were immediately symptomatic. But this was true for patients who were not symptomatic in the first place. So what we know about acid blockade is it's so good. PPI therapy is so good for acid blockade that you will have hyperproduction of acid post-discontinuation, and you have to wean it to try to help them, or you have to modify them with something like an H2 blocker for a short period of time and wean it over a few weeks. Because people may feel like I can't stop them because I'm too symptomatic when I try. So I tell them it's going to take you a month. If you're still symptomatic after a month, then we need to figure out why. Okay? And we're now finding many more people with other conditions, such as functional dysphagia, for example, that have no role for acid symptoms. And sometimes pH probe studies are actually helpful to diagnose these conditions. Hypersensitive esophagus is another condition we're finding now. So the same way you can have IBS of the intestine, you can have IBS of the esophagus, if that makes sense. This is an older kid, of course.
When you say, taking it out of the infantile reflux, if you have an older kid who sounds like, acid reflux, that kind of thing, would you still say, okay, for the general pediatrician to try a month's worth of an acid blocker, say, okay, you're feeling better? Generally, if they have to be long-term, I said, then you just make
That's right.
something else.
I really think that's the perfect approach. Acid blockers work, right? I mean, they're tremendous. We used to see, especially in the developmentally delayed population of patients with G2 fed and CP kids, we used to see gastrointestinal bleeding all the time, right? We used to see gastric ulcers all the time. We don't see them anymore. And one of the reasons is that acid blockade is incredibly effective. We just have to pick the right patients. And so if a kid, if a very high-strung kid who's having very classic symptoms of reflux, I think it's perfectly adequate to try 2 months therapy to see if their symptoms resolve, but they should be able to be weaned off of it. If they're not able to be weaned off of it, we need to know why. You know, in the adult population, they're much more comfortable to say, you have a hiatal hernia, you have, you know, reasons for lifelong TBI. In pediatrics, we don't feel the same way. We feel like we need to know why we're signing up somebody for a lifelong therapy. And so in that case, they'll either undergo a pH probe or an endoscopy to look for EOE or another condition. Okay. And I have found it, you know, candidiasis and things like that in kids who were symptomatic for birth. Thank you very much.